Thank you, Alice. So right now, let me take this opportunity to introduce our panelists for today. We've got 3 panelists. We've got Ms. Gertrude Mncube and Mr. Daliso Mumba and Mr. Andreas Jan. So I'll start with Gertrude Mncube. She is the National HIV Prevention Coordinator for the Zimbabwe Ministry of Health and Childcare. She has spearheaded the introduction of the new evidence-based interventions in biomedical prevention, including PrEP. So PrEP in Zimbabwe. So we're very happy to have her with us today as one of our panelists. And I would also like to introduce Mr. Daliso Mumba from the Ministry of Health in Zambia, who is the civil society coordinator at NEC Zambia, and currently oversees, among others, the GFTAM financing targeting HIV services to key populations and the implementation of PrEP within the country through a task force. And lastly, we have Dr. Andreas Jan, who's with ITEC Malawi. He's a clinical epidemiologist with 20 years of working experience in Africa, primarily in HIV. He has worked in the academic and the program sector, and he has profoundly contributed to the National Art and PMTCT program in Malawi, with innovative strategic information systems and policy and initiatives such as Option B for PMTCT, which has been adopted as a global recommendation by WHO. This was in 2013. He has contributed as an external expert on the WHO Clinical Guideline Development Committee since 2012. So welcome to our panelists. And we will then begin our sessions shortly. Can you all see them? Yes, are your cameras on as we begin this discussion? So then we will start. I think we will start with Dr. Andreas. If you can tell us, what has your experience been with monitoring PrEP implementation amongst adolescent girls and young women in Malawi?
Thank you. So it's a pleasure to join this think tank, and I'm afraid I've missed all of the other sessions, so I'll be educated by my fellow panelists and by the colleagues joining us on the chat. So I just wanted to briefly give a very small background, because I think Malawi is probably behind several other countries in the region in terms of PrEP implementation. And there are some reasons for that. I think one of them is that we've had a number of demonstration projects that have met a few bumps essentially along the way. So we've had one implementation study in Lilongwe amongst adolescent girls and young women, where PrEP was given in the context of a formal study to measure the uptake and the retention. And the findings have been fairly disappointing. We've learned a number of lessons there. But we've essentially now completed the design of the monitoring system for the national program. So I'm working for the Ministry of Health for the HIV department. And so my perspective is very much on the kind of public health aspect of what is feasible within a Ministry of Health system. I think what we've seen for PrEP certainly up until now is that it's very much dominated by implementing partners with certainly much better resources in terms of implementation, but also in terms of data gathering and reporting. And so the challenge really that we've had is to try and trim it down to something that is scalable, implementable, and also has a chance to be sustained in the hands of a much less well-resourced setting in the Ministry of Health. I think there are a few important considerations that I wanted to mention that I think need to be discussed in terms of the M&E system, certainly for PrEP. The first thing is that Malawi is not KwaZulu-Natal, so in terms of HIV incidence in all populations, but particularly amongst adolescent girls and young women, incidence is much lower, still high, but much lower than in South Africa. So I think the aspect of targeting is really essential and needs to be incorporated in the monitoring systems as well. And just to illustrate that, I wanted to just briefly share a few numbers. I'm an epidemiologist, so that's kind of my turf. But so we've engaged in a formal impact modeling exercise in 2019. We've used the GOALS ASM model. I think many of you might be familiar with it. And we've looked at various scenarios for scaling up PrEP for adolescent girls. And we've specifically looked at geographic targeting. So we have estimates for districts, at least rough estimates for incidents that allow us to do that. And so I think an interesting take-home finding here was that firstly, PrEP implementation to a meaningful, epidemiologically meaningful scale can be a significant budget driver. So for example, the first scenario we've examined is to cover 20% of all adolescent girls who are assumed to be in the higher risk subgroups in all districts with PrEP. That comes to an annual budget of $62 million with an average cost per infection averted of $108,000. And we've looked at more targeted strategies for the highest incidence district in Malawi, in Blantyre, of folk covering only 8% of adolescent girls in that district alone. And that still comes to $25 million budget per year and $60,000 per infection prevented. So I think the key in terms of monitoring such a program will be to have at least enough strategic information to see if the selection of participants is adequate, and if there's an appropriate follow-up in terms of the risk monitoring as well. So we've kind of tried to incorporate that into the patient cards, the client cards, and the registers we've come up with. And then I think the other important aspect, of course, is the adherence. We've all been concerned about this. We know that PrEP works really well if adherence is good. But as soon as you lose the adherence in the risk episodes, you get to very disappointing results. And I think that's key for a national program to consider, that there has to be some measure of adherence and retention in the program to provide essentially the information that we need to steer forward. I think in terms of the actual M&E system, there are just maybe two aspects I wanted to highlight that we've been grappling with and we've come up with some solutions for. One is firstly, of course, that PrEP is an open cohort. So these are individuals who come with episodes of risk. And so there's an expected start and stop and potentially restart, of course. So that's something that's quite difficult to manage in terms of a monitoring system. It's essential, I think, that we have primary follow-up outcomes documented to make any sense of the data. And by that, I mean things like loss to follow-up, of course, so unknown outcomes. Deaths will be few, but of course, that has to be covered as well. And then within the retention, I think we need to, of course, monitor the seroconversion, so HIV positive, HIV negative. It's essential, I think, to look at toxicity and then to monitor the ongoing classification of risk. And then, of course, we have to also deal with potentially transfers between facilities. So all of that makes for a fairly comprehensive and fairly complicated monitoring system. And we've been struggling to think how this could be brought to scale within the constraints of a ministry program. And so I just wanted to say that I think that we're at the very beginning. In fact, we have now a few hundred clients who have started on PrEP, primarily amongst implementing partners who've started the PrEP implementation for female sex workers. They are very differently resourced, and in terms of their capacity to make even active follow-ups, it's a whole different ballgame. But I think to make it meaningful for a national program and to really have an incidence effect that's measurable at the population level, we have to bring it to a much larger scale. And I think that needs to be the focus in terms of the M&E system as well, to come up with something that is scalable to a meaningful level and sustainable. So let me just stop here in terms of my monologue and invite my colleagues to chime in.
Thank you very much, Andreas, for those insights. I think you're bringing in very important and thoughts that have a lot of people, a lot of us grappled, thinking about how do we do this, complicated M&E system, how do we do our targeting, how do we constantly define need as the need for the individual changes, and how do we capture that So very, very interesting insights. So I'll now move over to Gertrude. So Gertrude, in terms of Zimbabwe, what has been your experience in Zimbabwe as you've been transitioning from demonstration projects to national scale up? And can you also enlighten us a bit on the database that you have, and as well as the partner dashboard? Thank you. Over to you, Gertrude. Sorry, Gertrude, you are muted.
Sorry. Good morning, colleagues. Good morning, everyone. Sorry for that. I'll start from the beginning, where Zimbabwe, we adopted pre-exposure prophylaxis. And when we adopted it, we said it will be in a phased-out approach. And when we looked at that phased-out approach, we actually said it has to start where I think we've got resources to start with to implement pre-exposure prophylaxis. And this was where we're saying we had resources. We actually looked at the DREAMS districts in the country. By then, the DREAMS districts were about 6 in the country, but we started on the 4 districts in the country. Maybe just a lesson which we learned from Zimbabwe, we didn't actually say the implementing partners should actually start the PrEP. It actually started as a government initiative when we adopted. And then when we looked at that, the demonstration projects were actually to give us lessons on saying, what is it that we need? Who is the target group? Who is supposed to be getting PrEP? And already as a country, we had that technical working group. That technical working group involved the funders, the implementing partners, Ministry of Health, our M&E colleagues, and everyone else. So with that, we actually said, what is it that we need to do? We actually said, we need to come up with data collection tools so that we need to see what we are collecting. And at the same time, we even need to come up with the demand creation tools, IEC materials, and all that, and then the capacity building. And then that actually helped us. What we then, after the demonstration projects, we had these demonstration projects for actually 1 year, while we were actually looking at our implementation plan. So in 2018, we came up with PrEP implementation plan together with our partners, working together, giving us information as well of what is happening through our technical working group. So then we looked at monitoring. We looked at the data collection tools which were actually being used to monitor, and then we transitioned it to our national database. Like we have got the DHIS2, which has got all our indicators, especially for our HIV programming. So we actually looked at what we're using during the demonstration project, and then we said, what are the key indicators which we need to transition into our DHIS2? So as I speak in Zimbabwe right now, PrEP is part of our web-based DHIS2, where in every district we have primary data source where we've got registers which we modified after our demonstration projects. And then with those registers, we've got our monthly data collecting tool, monthly report form, which actually is entered into our DHIS2 at district level, and it comes to the provincial level, and then it comes to the national level. So at a national level, we are able now to see how many clients have actually been initiated on PrEP, and which are those actually target groups which we came up with. It is the adolescent girls and young women, we've got the female sex workers, and then we've got the MSM, and then we've got serodiscordant couples, and the other indicator which we collect is those who actually, others who perceive themselves to be at high risk. So we collect using that information. So we realized again, because some of our implementing partners, they were not entering data within our DHIS2. So then we actually came up with saying, why is it that it looks like looking at the number of supplies, logistics, or commodities of PrEP which have been provided, is not actually tallying with what the information which is in the DHIS2. So what we did was we came up with a sort of like a dashboard, which our implementing partners, they are actually using at the same time, using the DHIS2, so that us at national level, we are able now to look at how many people have been initiated, and then the DHIS2, and then we say, partner, give us all your data so that we see, we compare, we triangulate the data to say, is it the same number of initiations and all that? Because some of them, they do mobile initiations, and at the end of the day, maybe with that monthly report, they don't report within that monthly report and then send it to the DHIS2. So we have actually come up with that dashboard, which shows us the number of new initiations disaggregated into age groups as well, which is the age and all that, and who is actually even, that dashboard actually is even informing us on the continuations as well, how many people are actually continuing on the pre-exposure prophylaxis. So for us to come up with that, for that monitoring, which we are actually looking at, we had actually to do a lot of issues as well, a lot of training, and it was really a challenge that at times our data was not within our DHIS2. So that's what we're actually looking at as well. But I can say now, pre-exposure prophylaxis is in our national the district health information software, our web-based database, and we are able to, here and there, we have got challenges, but we've tried to say how best we can overcome those challenges and all that. So this is what we have actually been doing. But what we can say, we learned lessons from the demonstration projects on saying who is our target group, how should we monitor, how should we actually make our registers user-friendly. We are still using that, but I'm looking at the long run, we need even to have an electronic monitoring system. And as a country, we are actually working on that, to have an electronic monitoring system, and our PrEP register will be part of that electronic monitoring system. Thank you.
Thank you very much, Gertrude. That is actually quite exciting. It's commendable that within a very short space of time, you've really moved the PrEP program forward. The fact that now PrEP data is actually reported through the national database, it's actually quite commendable. That's great. We will move over to Mr. Daliso. Can you tell us more, Mr. Daliso, about your experience with monitoring PrEP implementation in Zambia?
Okay, thank you very much. Thank you very much. Good morning, everybody, once again. I hope everybody is staying safe within the current pandemic. So I think similar to my colleagues from Malawi and Zimbabwe, I think with Zambia as well, we did start off PrEP implementation with demonstration projects. I think this was around 2016, 2017, with about 2 sites, which were mainly supported by University of Maryland, which is one of our key partners for PrEP implementation. During this period as well, we initiated the development of the National PrEP Implementation Framework and Guidance, which basically was our guiding document for full-on scale-up for PrEP services within the country. And this document was developed in collaboration with our various implementing partners, Ministry of Health, as well as other institutions. And this document provided some minimal guidance, not too much of it. I think around this time, even WHO hadn't provided significant guidance around PrEP M&E. So this guidance basically provided a few indicators which were mainly focusing on the proportion of sites, ART sites providing PrEP, the number of individuals who received oral PrEP to prevent HIV infection, as well as the total number of older new active PrEP clients, which is basically PrEP new and PrEP car. The document also provided guidance, a list of tools which could be used for providing PrEP services, mainly the registers, the initiation form, as well as the follow-on form. The tools were basically there to provide monitor safety and effectiveness of PrEP implementation. So during our initial phase, of course, we didn't have so much information on when it came to PrEP M&E, and we were basically looking at these 3 main indicators as well as the tools. However, We do understand that PrEP monitoring and evaluation still remains a significant challenge, and mainly because of the absence of population data in the country. This is basically looking at the national targets and indicators. Most of the targets that we do have are program-based targets, which our partners themselves set for themselves, or PEPFAR, for example, sets for themselves. Also to mention that PrEP in the country is mainly supported by PEPFAR. They are our main supporter for PrEP implementation in the country through their implementing partners across the country. During this period as well, we did see a significant increase in the number of sites providing PrEP within the country. I think at the moment, all provinces in the country, or all districts in the country, do have PrEP sites. So like I was saying, we don't have population-based targets or indicators. We're only at the phase of where we're more or less coming to set up some targets which you can use for PrEP implementation. The other challenge that we have as well is that we're poor integration of our PrEP data into national M&E systems. So unlike our colleagues in Zimbabwe who are way ahead of us, we haven't yet integrated most of our data into the national M&E systems. We rely on our partners from PEPFAR who provide us with data on a semi-annual basis through the PEPFAR reporting system, also known as the DATIN. However, we're not just sitting back. I think we're making strides to move forward. Even as we've scaled on PrEP to a national level, we understand that M&E remains very key for us to implement PrEP. And what we've done as a country is we've started the development of the national M&E framework for PrEP. Basically, this document will be a guiding document for PrEP implementation, for monitoring PrEP implementation in the country. And the key main objectives of this document is basically to standardize monitoring and evaluation of PrEP services. So like I mentioned, we don't have an MOH or Ministry of Health approved monitoring system. So we want to standardize so our partners can all report using the same tools and report within the same system, so that this data can be available at national data, and we don't always have to rely on our PEPFAR partners to provide us with this information. We also want to ensure that we set targets, national targets and indicators, so we can monitor and supplement indicators along the PrEP cascade. Like I mentioned as well, we don't have national indicators. Most of our indicators or targets rely on PEPFAR targets, which partners use to reach out to the various populations. We also want to promote a data-driven approach to PrEP services delivery for program improvement and decision making. And lastly, we also want to present a cost-effective methodology for PrEP. So this document at the moment is currently being reviewed before publication by the Ministry of Health and remains our key guiding document for PrEP implementation. Now, when we talk about PrEP, for example, for adolescent girls and young women, I think adolescent girls and young women are one of the largest populations that we've reached out with PrEP services. I think there are numbers amongst all other populations, which include female sex workers, men who have sex with men, pregnant and lactating women, serodiscordant couples, and so on and so forth. They're always adolescent girls and young women are always in the higher percentile, so usually ranging about 34% of the population that is reached with PrEP services. Of course, there's still significant challenges with reaching out to services for adolescent girls and young women, mainly because of the social norms, also access to where we can provide these services as well for the younger populations, also stigma and discrimination associated with receiving PrEP services. Girls fear they might be perceived as being promiscuous and so on and so forth. However, through program data, we continue to monitor the number of girls that are accessing these services. And of course, the biggest challenge, like in Malawi, is that we don't have a high retention for people on PrEP. And this may be due to various reasons. Maybe due to drug fatigue, it may be due to the side effects, it may be due to diminished risk, it may be due to stigma and discrimination, it may be on the end of the client themselves, so perceived stigma, or it might be poor service delivery from our healthcare workers. So we understand that we still have to constantly monitor and collect this data for us to improve our services, particularly for PrEP for adolescent girls and young women. And I think that is one of the reasons why we want to roll out this document the PrEP M&E for monitoring PrEP implementation within the country, the M&E framework. And hopefully, once that provides guidance of how we can use the program data to inform decisions and where we can improve in order to improve quality of service, it will be better for a country as we move towards full-on scale for PrEP. We're also in the process, I'd like to mention that we're also in the process of just starting to do some demonstration projects for the DVR as a country. So those are some of the things that we also want to learn from PrEP and see how we can, the lessons we've learned from PrEP can be taken onto the DVR, which should come onto the market in the country within 12-month period. So in a nutshell, I think that is where we are as a country when it comes to PrEP M&E framework. We still don't have a national system, and we're working towards that through the PrEP M&E framework. Thank you.
Thank you very much. Thank you very much, Mr. Daliso. I think it's also very exciting to see that there's a lot of work currently going on, even in Malawi, and the fact that we are really thinking about M&E and the role that it plays in ensuring that PrEP is provided and provided well, and to ensure that it's effective, and we can at some point be able to look at its impact as well. I think what's also coming through from Dr. Jan, I'm just thinking about it, that talking about effective targeting, so that as we implement PrEP, it remains cost effective. How do we define risk? How do we ensure that we strategize in a way that we are able to scale up? Because if it's still too expensive, then we really cannot see any benefit to it. And touching on what Gertrude was saying about moving on to online platforms so that we are able to have a full view of implementation and what's going on. And you talked about, Daliso, about a national framework. I like that it's actually a well thought out process when it comes to M&E. So it would be very interesting to hear what you have to say in a couple of years, perhaps when you're on a platform like this, once again, Mr. Daliso, sharing your experiences with implementation. So just to follow up, Andreas, what has worked well for other specific interventions when it comes to monitoring the effective use of PrEP? Are there any transferable lessons that you've learned that you would like to share with us?
Thank you. So yes, I mean, as I said, we're at the very beginning of implementation outside of demonstration projects. So I think I wish the meeting was 6 months later. We would have probably more to share. But I wanted to say that I think we have modeled the entire M&E system very much on the ART program monitoring system that was designed, in Malawi in 2005, so a long time ago, and has been quite successful for a very long time on a purely paper-based system. And it worked, I think, because we have regular supervision of all the sites. So there's an oversight, there's data auditing happening. We're looking at primary records. And I think that has been key for the ART program. And we're hoping to kind of transfer that same lesson over to the PrEP program. From experience, certainly it's been far more difficult to monitor effectively community-based programs because that kind of level of access to primary records is much harder to deliver for a ministry. And I think that that's why I'm also, I proposed in the chat box that, I think two of the kind of key entry points that I can see where meaningful PrEP implementation could happen is within the STI clinics and the family planning clinics, because we have huge numbers of patients or people accessing these services. We have routine HIV status ascertainment already, so it's an automatic eligibility check. Essentially, if you have an STI patient who tests HIV negative, it's a fairly safe bet that this patient might benefit from PrEP. And so I think that even without trying to elicit potentially stigmatized behavior, you could very easily make a simple, recommendation that somebody might consider taking PrEP. And I think with adequate information, I think that would also potentially, make the acceptance much easier, because I think we're, at risk certainly of having that key population label on PrEP. which is going to be really off-putting for many people who don't consider themselves to be part of such a subpopulation. So I think that aspect shouldn't be missed from the beginning, also in terms of how we monitor. So we've discussed for a long time internally whether we should even attempt to document stigmatized behavior on a client intake form, or on the client record, because we know that this is going to be a challenge both for the provider as well as for the respective client to disclose, and it might give the entire PrEP program a bad name in terms of being only for specific subpopulations. So I think that might be two things to really think about. I think from my perspective, certainly of working in this program for so long, I think integration into existing service delivery points will be a key to bringing this up to meaningful scale. That doesn't stand in the way of providing PrEP within drop-in centers and key population projects. That's I think a given. But I think that to bring it outside of that realm, I think we have to think very differently. And I think we have to be careful that we don't label it from the beginning as something that may prevent access and uptake in a much wider population that would benefit potentially from it. I had posted a few questions to colleagues because I was just curious if anyone had attempted to do that. So one of the things that we noticed from our demonstration project is that we have actually seen a concerning number of new STI episodes, as well as unwanted pregnancies and a few serial conversions in the PrEP demonstration project for adolescent girls. And I think that will be a key, certainly for a responsible public health program to keep an eye on, to monitor and make sure that we don't, inadvertently encourage, further risk-taking behavior without appropriate offers of prevention measures. And I think that I just wondered if anybody else has any information on this, what's been collected for example, in Zimbabwe, because I think Zim is further ahead of us. It just struck me that this is a really important part beyond, counting the PrEP initiations, looking at person years on PrEP, so the kind of exposure time, as well as these secondary outcomes that strike me as really important to keep an eye on. Over.
Thank you, Andreas, very much for those insights. And I would like to encourage colleagues that please use the chat. Andreas has posted the question there. Can we start engaging with it? Perhaps when we have time, we will talk about it. We'll bring it up and talk about it. But please feel free to comment and respond to the questions that are on the chat. So now, Gertrude, going back to Zimbabwe, we talk a lot about engaging adolescent girls and young women in our efforts, as we do. We with them, we cannot do this without them. So how have you incorporated other types of data and perhaps insights as well to inform your programming for adolescent girls and young women in Zimbabwe? Over. Gertrude, please
unmute. Thank you so much. Thank you so much, Mopo, for that question. Maybe looking at adolescent girls, I think I even alluded to the fact that we have our DREAMS districts where we've really interacted with adolescent girls. And initially we had 16 districts, but now we've got about we had 6 districts, but now we have got about 16 districts. That's through PEPFAR. And through Global Fund as well, we have the DREAMS districts where we are actually interacting with our adolescent girls. But when we started PrEP, what we did was what we call empathy, insight, and prototype of adolescent girl. This is a way of actually trying to spend your time. We had our colleagues who actually looked where we're looking at demand generation, where we actually had time where we spent with adolescent girls and discussing about PrEP, where we spend our life like you spend a day with an adolescent girl, and where we're saying, what are the barriers if we are actually talking about PrEP? What do you think would be the barriers? What would be the facilitators? And you spend your life in a day in the life of that adolescent so that you will understand better, especially when they are saying we are interested in pre-exposure prophylaxis, but we've got barriers. And some of them whom we interacted with those young women selling sex, where they actually were to understand better, to say, if we say you need to access it in a health facility, what time should they come and all that. So we have actually even developed a communication strategy. And in that communication strategy, we've even used a human-centered design where adolescent girls have actually told us who are their influencers, what are their barriers, what we need to consider and not. And that actually helped us into saying, like now we are actually looking at the issues of continuation of PrEP when we are monitoring, especially with the adolescent girls and young women. We are, especially with the, maybe because we start PrEP from 15 years and above for those who are supposed to be given PrEP. So we monitor them and see what is happening. So all those insights which we got from them, the target audiences, they actually helped us. We actually, even with the PrEP program for the adolescent girls, we come up with what we call peer supporters or PrEP champions, which have actually helped us as well, where if we initiate someone on PrEP, they either actually they live with those adolescent girls there, they actually identify those maybe who are at substantial risk, but when they get into the health facilities, that's when we use that screening tool to really see that they are really at a high risk of getting HIV. So we use all those peer supporters. We use even the PrEP champions, which has actually helped us as well in the monitoring. And if they've got, whether they've got challenges with access of services, we actually use those people to actually help us as well in the monitoring as well for effective use of PrEP with adolescents. We have sort of like an insight on their journey mapping to say, what is it that they need? Do they need, like initially when we started, we're actually in our health facilities of giving PrEP within the OI clinics, but then the adolescent girls, with interaction with them, they said, no, is it not possible that we can even get PrEP within maybe in the outpatients and all that? So we have, in other areas, we've actually made a way to say these adolescents, due to the interaction which we have got with them, we actually get those services. And some of them, they've even said, maybe we need you to come to our support groups where we meet and then maybe initiate PrEP in those areas. So we've actually interacted with them and listened what they are actually saying and tried by all means to actually be able to give them such kind of services. So I think what I talked about, the imaging prototyping and even the human-centered design and even the issues of PrEP champions and peer supporters within that, they've actually helped us in actually to monitor and see what the adolescents need on their barriers and facilitators as we implement or as we scale up pre-exposure prophylaxis amongst that. Thank you.
Thank you very much. Thank you very much, Gertrude, for those insights. It's actually quite exciting to see that you are engaging young people, not just for demand generation, but across the whole continuum of PrEP implementation and getting their insights and their thoughts on how these services should be delivered to them, how monitoring should be done. So that's actually quite exciting. So we will just take make one last comment from Daliso. We've really run out of time. I apologize that I have to tell you that before I engage with you, but if you can really make it quick, that would be great. So, I mean, we are all excited to hear that you are implementing at scale, and I think the plans that you have are really great. So we would just, if possible, can you tell us more about the next step, the steps you actually took from going from monitoring in a demonstration project to now demonstrating, not demonstrating, monitoring at scale. So how did you move? How did you do that? Monitoring at demo level and now moving on to scale. How did you do that? Share those learnings if you can, please. Thank you, and over.
Okay, so I think very quickly, I will mention that I think the key thing when it comes to all of our implementation of PrEP is that we developed a task force which was spearheading all processes, whether it was M&E, guideline development and training and so forth. And this task force basically encompassed the various implementing partners, line ministries, experts as well as our donor agencies such as WHO, USAID, CDC, and so on and so forth. And in essence, the purpose of this was for us to work collectively and provide guidance on how we can move from a demonstration project to a national full-on scale-out. And like I mentioned, I think the key issue as well was us developing a guiding document, which everybody can relate to when it comes to PrEP M&E. As much as it wasn't sufficient, we've moved on now to develop the national PrEP and M&E framework. So we've taken a more or less of a gradual process from a demonstration to having the guidelines to having now the M&E framework on M&E. But also what's very important is training of our healthcare workers or our data collectors on M&E persons for them to understand what type of data to collect, how to use this data, how to report this data, and how to interpret it. It's very, very, very important. Also, we need to educate the community themselves, the beneficiaries. They need to understand, for example, when it comes to follow-on visits, what is it that they should ask the doctor or they should ask the clinician to check on them. So in a very short, not to take too much of your time, I think that is how we've taken the process from demonstration to full-on scale. I hope I did that under a minute. Thank you.
Fantastic. That was brilliant. Thank you very much, Daliso. So now we'll open up to questions from the floor. But before we do that, colleagues, I want to encourage you, please make use of the Jamboard for your suggestions and questions. It's really fantastic. Just go have a look at the Jamboard and you'll see what others have done, and perhaps it will also prompt some questions from you. But if you have a question, put it there. It's actually a fantastic platform to use, the Jamboard. It's a lot of fun. It has a lot of colors. So you should have fun engaging with it. So now we have one question that we'll direct to our panelists, and perhaps others can also input. And if they have comments, seeing that this is actually a learning platform for all of us. So the question that we have here, which was posted on our Jamboard, is, has any M&E system been able to measure person years on PrEP? Initiations alone are not a very meaningful measure for PrEP implementation. So I would direct that to you first, our panelist, for your thoughts and around the question. Over. So I'm not sure who would want to go for it first. Shall I start with, I see Andreas and then Daliso.
So it was actually my question, because I suddenly, we don't have that data. We have it from a demonstration project, and I have to say, I've been involved in the analysis of the data that's been collected, and it's a real struggle. It's an interesting intellectual challenge. And I was just curious, given that our neighbors are further ahead in terms of implementation, if they've attempted to look at that. Because, I think, of course, in terms of the impact, we're looking for as much coverage as possible in terms of risk episodes with PrEP exposure. And so I wondered if anyone has attempted, I know that the PEPFAR indicators are quite limited. It's only new initiations and currently on. but that doesn't really tell you very much about the person years on PrEP that we've achieved in the program. And I think that's the key, of course, for measuring effectiveness and impact. I was just curious if anybody had thought along these lines and if you've had any luck trying to construct that from your data. Over.
Thank you very much. Thank you for that clarification, Andreas. So we can have a discussion. I'm not seeing any hands right now. So perhaps some of our colleagues who are also on the call can actually weigh in, especially from countries who've had a lot more experience with implementing PrEP. It would be great to hear your inputs on this question. I will repeat the question for the sake of those who may not have heard it. Has any M&E system been able to measure person years on PrEP? Initiations alone are not a very meaningful measure for PrEP implementation. Yes, I think we are all aware that people initiate today and they drop off tomorrow. We don't know whether it's because of poor engagement or their risk has changed. So in terms of looking at effective use of PrEP, meaning that when they need PrEP, they are on PrEP. So how do we have any? Okay, we will, as we're waiting for more inputs from our colleagues. Daliso?
Hi, not at the moment, but I think it's something that I think before we finalize our M&E framework, we'll look into. So we haven't yet started looking at M&E on person years. Yeah.
Okay, so I'll have a look here at the chat as well to look what other questions colleagues have posted. Please feel free to raise your hands as well so that that may be easier. Gertrude, do you have any inputs?
I was saying not at the moment of the person years, but what we've been monitoring is actually on the continuation. We have a cohort of actually clients where we'll actually be monitoring the continuation. And maybe I must say, maybe there's need to do that, but for the monitoring the person years, but on the continuation, as Zimbabwe, we've actually data to say, and on average, we've actually seen that people, they continue on pre-exposure prophylaxis for 6 months. But if I'm looking at adolescent girls on the data which we have, most of them, they actually fall off after 2 months and all that. But those are these areas as well where we are actually engaging them to really finding out why they discontinue and all that. Some we've got actually the reasons why they are discontinuing, but on the number of years we haven't. But we monitor, and especially even our dashboard, it actually shows us to say for how many months or for how many. But the longest who continue for maybe about 9 months is about the serodiscordant couples as well as some female sex workers. Thank you. I hope it's useful information.
Thank you very much. Much useful, Gertrude. I think this is a great platform for a lot of us to learn from what others are already doing. So another question we have, we know from consultations and emerging evidence that there's a need for community to be strongly involved in any PrEP programming. I mean, how can it be brought to the table, and how could we design monitoring systems that would be able to capture this? So we know that community engagement is very important. Strategic engagements with communities are important in promoting the uptake and retention on PrEP. But how then could we meaningfully measure this with our M&E systems? That is the question to our panelists. Over. Are there any hands? Let me just, so I'll leave that over to you. Dalisa, would you like to get started?
Okay, I think in any type of programming, involving the beneficiaries themselves is always key when it comes to implementation, whether this be through M&E or whether this be through communication, through trainings, through providing the relevant information. Sometimes it may be difficult to measure community involvement. It depends on what you're measuring. For example, are you measuring how much information the community knows about the certain program? Are you measuring, for example, how many people in the community are receiving that service? I think constant program data, surveys as well on a regular basis will help us understand how well the community is involved in a program. And usually this can help us understand the level of knowledge that the community has in that program and how well they are involved. We could also use our community health volunteers. They're very key. I think most of us do have community health volunteers on the ground, and they can help us assist. They can help us assist and gather information on what the community knows and how well the community is involved in implementation. Especially for programs that relate to HIV, we're still well aware that, for example, even condom programming is still a very difficult topic in most rural communities. Even PrEP, for example, there's still a lot of misconceptions when it comes to PrEP. But working with community leaders as well and understanding how they can help us reach out to these communities is very, very key. For example, on some of the projects that we've worked on with key populations, we've understood that working with key populations, civil society organizations, or gatekeepers within the key population community is very, very important in reaching out to this community. You find that most of the time, key populations will not be open even for other services beyond PrEP to receiving these services if they're not working with people who they're familiar with. So sometimes working with people from the community or getting community health volunteers who are part of this community can help us assist reaching out to these communities, and it will also help us understand how well the community has been involved and to what level they understand the services that are being provided to them. It's a similar situation with adolescent girls and young women. We all know that it's easier to have peers who are adolescent girls and young women reach out to their own adolescent girls and young women rather than use older people to reach out to them, because only then will they understand these services from the people who are part of them as well. So thank you.
Thank you very much, Daliso, for those insights. I was just also thinking here about CAP surveys, knowledge, attitudes, and behavior surveys to assess. Those are also very important before we start, as we are going through, when we've started with implementation, just to weigh in to see how perspectives and how attitudes are changing within communities. I would also give over now to Gertrude. Do you have any perspectives on that to share? On how we can meaningfully measure or monitor community engagement when it comes to PrEP implementation? Your thoughts?
Okay, I think like the issues of surveys and like what I've alluded to, that we have what we call PrEP champions, especially for our adolescent. It's sort of like a way of actually including as well the communities as well. And I think what especially with our HIV programs, where we are now sort of like encouraging communities to sort of like have community-led monitoring, where we're actually looking at maybe different subpopulation as well, where we are working with communities to really look at community-led monitoring of our HIV programming as well. And I think these ones, they've actually assisted as well. I'll talk of the key population program, where we have got what we call community-led, where the subpopulations for the KP program are actually assisting that. I think from the lessons which we have learned from the KP community-led programs, we can employ them into our PrEP programs as well, not only for adolescent girls, but for the other populations at risk. Thank you.
Thank you very much. Before we take the last question, Andreas, do you have any perspective on this? Any insights to share? Over.
So, I mean, echo the sentiment. I think, that of course the kind of information messaging to the community is essential. I've just, posted a little anecdote in the chat box because we were so struck by that. So we've seen a decline in access of family planning services because there's some perception going around that women might get vaccinated against COVID, which seems to be something that people are trying to avoid. So I think, there's something that you have to almost anticipate and do, appropriate work in terms of messaging before you attempt to roll out anything. And I can relate to this certainly for the key population projects. It's a far easier game than I think to bring that kind of information into the general public. And I think, that's why I said I think integrating into, say, family planning or STI clinics might be a much more promising strategy. But it's essential, I think, to have people understand and have appropriate perceptions about the risks and the benefits of this intervention. And I'm not sure what more can be done, but I think we've probably collectively not done a fabulous job in getting ready for this. Thank you.
Thank you very much for that. Thank you. You've provided to the three of you. You've really provided great insights on these topics that we've covered today. And just to extend the question that we had earlier on being able to measure person years on PrEP. I do believe we have academics and epidemiologists and all sorts of great people on the call. So if they could also weigh in on that question, and I think it's Andreas would really like to get feedback on that question. So it would be great if we could just discuss it. I think it's a very important question, and yeah, just to share some thoughts. So now we're extending the question to the floor. I think this one, everyone wants to think about it some more. I'm not seeing any takers. And Andreas, I'm not seeing any takers. I want to encourage you once again, though, colleagues, please make use of the Jamboard, post your questionnaire and comments, the comments that you may have. Alice, would you like to take us through the Jamboard? Maybe one or two questions that are there, or should we proceed?
Thanks, Mopo. I'm happy to share the